Hello, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, we are here live with the Chief Medical Officer of the Centeno Clinic, Dr. Chris Centeno. Good morning, Dr. Centeno.
Good morning, Jason.
Good afternoon where you are, morning where I am, and we've got a really great topic today. I know this works hand in hand with one of your recent blog posts, and today what we're really exploring and digging into are the differences in the types of people or professions or training that people have in doing different types of procedures. Specifically, our topic today is understanding the difference between an MD, a DO, an ND, an NP, and a PA. A lot of words or letter salad there. Let's break them down individually. And the reason you want to pay attention if you're new to this conversation is because there's lots of different types of practitioners that claim to do something similar, and yet nothing could be further from the truth. So, Dr. Centeno, let's break down why the same thing may not be the same thing depending on who you're getting it from.
Yeah, so, we often see these abbreviations, and it's hard to really conceptualize as a patient what they are and what the differences in training are. I mean, it's hard enough just to deal with the differences in training between one MD and another, which could be huge and substantial. But here we're going to actually go into these different categories and break them into some subcategories. So the first one I'll go into is an ND, which is a naturopathic doctor. And an ND generally doesn't go to medical school in the same way that your local medical doctor down the street goes to medical school. They go to a naturopathic college, and their training is very, very different than a physician. For a physician, you go through, for instance, an internship where you're in a large hospital. You're seeing all sorts of stuff, everything from people dying to people coming in to the ER who are severely injured, to surgery rotations, etc. In an ND setting, you don't really get any of that. It's pretty much all well care. So what that means is, trying to use supplements or other sorts of natural things to try to help somebody. But there's none of that exposure to really sick people. And there's a huge difference between a medical doctor's training level and an ND. An ND would probably be a third of what the average MD gets trained in these days. And again, one in well care, meaning taking care of people who have allergies and things like that, versus someone over here on the ND side who gets to see a gamut of everything from people who aren't very sick to people who are on their deathbed, people who have trauma, etc. So there's really no comparability in an ND and a physician's level of training. They're vastly different. Now, despite that vast difference, we see many NDs that are entering in to perform these procedures.
Bless you. Okay. And that's really what today is all about. I mean, every profession has their specialty, their uniqueness, their unique philosophy that drives what they do. That's really the key. Hopefully you can hear me better. I thank you for your feedback. We'll work on the volume. So thank you for giving me feedback. Hopefully I'm a little louder. I'll bring Dr. Centeno's audio down in just a moment. So thank you for giving me your feedback via the comments. What we're really looking about here today is the confusion that takes place often when people are hearing the words stem cells, thank you, and then think that they can get stem cells from just about anybody who can figure out a way to get them into the body. And that's really the sort of difference in what you want to know today. If you're shopping around to understand, is this the same as this? Are these apples to apples? The answer is no, they're not. That the doctors trained specifically at Centeno Schultz, let alone specifically as part of the Regenexx network, have a different level of training than even, I'll say regular MDs. Doc, should people be considering procedures by any of these other professions, or is really the takeaway from all of this is we're all trained differently, and if you're not receiving a procedure by somebody who is trained as an expert, and that's not just any MD, that is trained specifically in this category, is that the takeaway message for people here?
Yeah, I think that the takeaway message is really to try to recognize what these abbreviations mean, and understand that so you can have some idea of what the training level is. So obviously at Centeno Schultz, we're MDs and DOs, so let's cover that. Those are physician level designators. So that means that someone went to 4 years of college, they went to 4 years of medical school, they did an internship, and then they did additional residency and or fellowship training after that. So while an ND that we were talking about might have 4 or 5 or 6 years of total training, the average physician has 12, 13, 14 years of training to get where they are. So when it comes to MD or DO, those are approximately equivalent these days. And you're talking about physician, and then that physician has to have additional training in this area to do this stuff. So very different than an ND. And then we also have those other two abbreviations I included, PAs and NPs. Those are mid-level providers. So what a mid-level provider means is that they're not physicians, but someone who took half or less the amount of training as an MD or DO physician, and who actually is really being employed more as a physician extender. So they're there to try to help the doctor see more patients. Again, kind of at a similar training level to a naturopath, but more medically focused training rather than more well-care focused training. So again, just to review, we have naturopaths over here, that's the ND. We have mid-level providers, PAs and nurse practitioners or NPs. And then we've got, fully trained providers, MDs and DOs, who then would need additional training on top of that to do this stuff well.
All right, we're starting to get some questions in. This looks like this one was submitted in advance by Harold Chesterton. Which of these has the training to do spinal stem cell injections correctly and safely?
Yeah, so none of those other than MDs and DOs who have further subspecialty training in that area. So for instance, you would need to have, let's say, a residency training in physical medicine rehab, and then on top of that, additional fellowship training in doing interventional spine. So a naturopathic doctor or an ND would not have the qualifications to do that. In fact, their practice acts in all the states I have reviewed would not allow them or permit them to do those procedures. Now, that doesn't mean you might not find some that are offering some of those procedures, but that's violating the law in the terms of their practice act, meaning they're not permitted in their practice acts to inject the spine or do anything in the spine. And again, same thing with a nurse practitioner or physician's assistant, not qualified to do spinal injection procedures, just should not happen. So that's that last category that we talked about. But again, you have to have additional training more than just your MD or your DO to be able to do that kind of work.
All right. So what I'm hearing is that the sort of mid-level assistants you should not necessarily be receiving these procedures from. When it comes to MDs and DOs, what are the types of questions that people should be asking if they are presented or if they're talking to someone who is an MD or DO, so they've got the qualified sort of, I'll say, basic training, minimum training? What questions would somebody ask one of those MDs or DOs to know if they have the type of training you're talking about that would qualify them, that you would say, you'd consider it as reasonably safe as can be?
Yeah, I think the first thing you need to ask is whether or not that doctor was fellowship trained in interventional spine. So here we're talking about a spinal injection, so that would be the first thing. The second thing is they're going to have to do that procedure under imaging guidance. So usually that's C-arm fluoroscopy or X-ray guidance. So have they been trained to perform that procedure under X-ray guidance? And the other thing to consider on top of that is that's where it gets a little bit hard to figure out, because we do have some doctors that are using X-ray, for instance, to do prolotherapy Hackett points in the spine, but they're not trained enough, for instance, to be able to document that they can inject a facet joint or epidural around the spinal nerves, etc. So it gets a little harder to figure out from there. The general rule would be, if someone's using X-ray guidance to do prolotherapy, they may not have the type of education necessary to do the more advanced procedures, like a facet joint injection or an epidural injection. So it's not super easy for a patient to really differentiate those two providers. Very easy for me to see. I can see that in a second, but very, very hard for patients to understand. So we still see a lot of patients that are getting scammed. They think they're getting, for instance, a facet injection with stem cells, but they're not at all. Nobody is actually doing that. The doctor's not trained enough to do that.
All right. And as you know, this program is called You've Got the Power, and our goal is to give you, the viewer, the power to make the right decisions for you and your health, decisions that you've got to make. Living in pain is not great. The standard, process of going, drugs when that doesn't work or when it hurts too bad, surgery is not necessarily the most recommended way to approach these things. Much of this does get complex, as you say, Dr. Centeno. So I'm going to ask this in one other different way, and then Damien will head to your question in just a moment. How would you describe the difference of the Regenexx training specifically? So, if somebody's out there sort of looking to find, how do I find somebody that's qualified? You go, okay, they need to be an MD or a DO, but even that's complex, when you get to sort of the micro details of what you're talking about. Is the bar, or is the filter, if you've been trained through the Regenexx network? And if so, how would you describe that difference?
Yeah, so realize in Regenexx, we do that work for you. So the first thing that happens is a doctor who wants to join our network has to have their CV reviewed by me. I review that CV, and I can instantly see whether or not they're qualified to be trained. And an awful lot of times, we turn them down right then and there. So we got to have that base level of training. Then we go to the next level beyond that, and that would be here's the training that you need to have, course A, B, C, D, and E at the Interventional Orthopedics Foundation and through that group. And then we'll do Regenexx training on top of that. Now, the positions at Centeno Schultz are even a level above that, because in order to work at Centeno Schultz, you have to have actually done a fellowship at Centeno Schultz, meaning that there's no physician who's employed at Centeno Schultz who didn't spend at least a year, if not more, training with us before they were able to become an attending at Centeno Schultz, meaning it would not be possible for a doctor off the street to come in and say, well, here's my training, I'd like a job at Centeno Schultz. Can't happen. So they're trained at an even higher level than that.
And that's why you're dealing with the best of the best at Centeno Schultz and the Regenexx network. And that's really what we hope you understand is, it's not just good branding. It's not just a self-proclamation. It's a lot of hard work and research and science and, doing these procedures over and over and over again, not just to get, the fastest growth, but really to create the smartest and safest place that you can have access to ask the right questions and feel confident and trust that you're able to talk to a doctor who has the skill set to guide you safely and properly. Let's head on over to some questions. We've got our friend Damien. How you doing, Damien? He says, Dr. Centeno, what is your least favorite body part and procedure to treat, and why?
Least favorite body part procedure? That's a good question, Damien. I don't know that I can answer that one easily. That's like sort of saying, who's your least favorite child? I've got three of them, and that's a tough one to answer. They're all different. So I don't know that I have an answer for that one. We created many of these procedures from the ground up, so they're all sort of my surrogate children, if you will. So I don't know that I've got a least favorite one. I can tell you, one of my favorites to do are knee ACLs that are torn, because that's incredibly gratifying when you get that MRI 3-4 months later and can see dramatic changes in the ligament. So that's a really fun one to do. I also like treating CCI because it's a extremely challenging, technically demanding procedure. After you do these procedures for a very long time, they sort of become rote in certain areas. But CCI is one that each time we do a procedure, there's some little pearl of wisdom that comes from having done that procedure that gets applied to the next one, because it's still so relatively new, and this area is completely uncharted, meaning that half of the diagrams you can see online, even where the ligaments go, aren't even accurate based on what we've seen over the last several years. Best I can tell you is those are two things I like to do, but as far as things that I don't like, that's a hard one to answer.
There you go. All right. Thank you, Damien. Great question. Good to get insight. Doug Smith, thumbs up, asks, after a knee stem cell procedure, is it recommended to wear a lockable hinged knee brace for a certain amount of time?
Yeah, it depends on what it is we're doing. So we use knee bracing primarily to offload a compartment or to provide stability. So for instance, if it was a knee ACL and the ACL was damaged, then we'd want an ACL stabilizing brace. Or if it's a medial compartment osteoarthritis in the knee, then we'd want a medial offloader brace, which takes weight off of that compartment that we just treated. So it really depends on what it is we're treating. Now, there are certain times we don't brace at all. For example, if you've got issues in multiple compartments, there's no way for us to offload multiple compartments. So, no brace is needed. So it just depends on what we're doing as to the type of brace and whether we use a brace.
All righty. He follows up with a second question. Great question. How is a DO different from an MD?
Yeah, these days there's not really much of a difference. I would say 30 years ago there may have. They're both competitive, complete medical programs. Many DOs go into medical residency training programs, and they're trained side by side with MDs. So there's really not a difference there. If anything, I think DOs generally come out of school with better hands-on skills than most MDs, so they're a little bit more trained in how to feel things on physical exam than we MDs are trained to do. I mean, I had to learn all that stuff from scratch from a local physical therapist and who was doing training in that area almost immediately, just to be able to get good at it, whereas DOs generally come out of their training with those great hand skills. And the same way chiropractors come out of their training with those great hand skills.
The best of both worlds, as they like to say. Stacy Kaufman, hey Stacy, thanks for joining us. She asks, why do so many neck patients develop tinnitus?
Yeah, that's an interesting one. As far as that's more CCI and upper cervical patients. I don't think anyone knows. It has been there ever since I've been treating upper cervical patients. A certain percentage of them will get tinnitus. No one's really 100% sure on what causes tinnitus. It's probably a neurologic feedback loop that's happening in complex neurology that we don't yet completely understand. So that's what I don't know. For instance, I can tell you why people get dizzy and lose their balance. That's an easier one because of proprioceptors in the upper neck. But tinnitus, much harder to explain, but it's definitely there and it's definitely real.
It definitely is. All right. Roger Chin asks, what is the minimum number of stem cells needed for the PICL? What happens if there isn't enough? He goes on to say, I had 989 M cells last September, but that was with hyperbaric oxygen therapy support. I'm not doing it this time as my condition has improved since the first PICL. Thanks again for providing this forum.
Yeah, so we don't have a minimum number for PICL. We did that research many years ago now, for knees, and there was a 400 million total nucleate cell cutoff. So that's the total number of cells in the sample, which is the same 900 million that you just discussed. So we don't have a cutoff. Now, based on other healing applications in ligaments, I would say that 400 million plus would be more than enough, and that number might go down to 200 million or so, given that it's far easier for bone marrow concentrate to heal ligament damage based on pre-post MRIs that we've been looking at for the last 16 years or so, than it is to do things like treat an osteoarthritic knee. So I wouldn't be as concerned about cell count with PICL. Now, we do keep a sample of every PICL patient's bone marrow in cryopreservation. So we take a tiny little sample, we cryopreserve that sample, and we're doing that because at some point we're going to go back and look at all those samples and see if there is a dose effect at all. So that's something we will probably get to, but right now I think the focus is more on the bigger things like do EDS patients and non-EDS patients perform the same? Do patients who have a classical picture of craniocervical instability perform the same as those who have a non-classical picture? So we're trying to get those big questions answered first.
I just have to pause and compliment you, just in my experience as a health professional, as a doctor, that it's just so refreshing to find the rare doctors that are so much more concerned about how do we do this better, how do we do this safer, how do we get better outcomes and results than the overwhelming majority of many doctors out there that are just trying to figure out how do I navigate the system and not go broke. And that really is, I'm going to say from my experience, a palpable difference between working with you, listening to you, watching what goes on in your practice versus what I've seen in hundreds, if not thousands of doctors who I've worked with, seen, etc. As a colleague and someone from the public, it is exciting and refreshing to see. So thank you for that. Let's keep going with questions. Doug follows up with, would a DO with a proper orthobiologics trainings be okay and equivalent to an MD with the proper training?
Sure, yeah, we have DOs in our practice, meaning that we have hired DOs because they had the requisite training. They competitively competed with their MD colleagues for a slot in our fellowship program, and they went through the fellowship program. So yeah, I wouldn't focus on any difference there between training levels in MDs and DOs. Where you really see the huge drop-off is when you go to a middle-level provider, NP, nurse practitioner, a PA, physician's assistant, or to an ND, a naturopathic doctor. Huge drop-off in training there. But between MDs and DOs that are similarly trained, I wouldn't have any issues. In fact, I've had multiple DOs within my practice inject my parts and pieces from time to time because I'm an old decrepit man, and I got little parts of me that are falling apart like we all do as we get older. So I don't care if it's an MD behind that needle or a DO in my practice, because I know that both are really trained the same.
Right on. All right, Damien goes on to ask, I'm going to read it out loud. What is your perspective on far infrared treatments to promote healing? And do you have a brand name that you would recommend?
Yeah, I don't think I've got a brand name that I would recommend. We use far infrared heating pads more along the lines of trying to improve blood flow while something is healing, because we tend to work on areas that have relatively poor blood flow. So I don't have a specific brand I'd recommend. We've been using a certain brand of heating pad in the office, and it works well. If anything, I think it sometimes works too well, where every once in a while we'll see someone who's stoking up too much inflammation naturally, and that stokes up more inflammation. So you can certainly reach out to the office on the brand that we use. But I don't have a particular favorite brand there.
Many in the proactive program that you have get that as part of their proactive membership. So it helps with the comprehensive healing. So let's keep going. Not a lot of time. Got a few questions left. Doug Smith follows up with, during my stem cell research, it was recommended I also do pulse PEMF therapy. What are your thoughts on this?
Yeah, so we studied PEMF. So just so people understand what that is, that's a pulsed electromagnetic field treatment. And we were interested very early on, it must have been 2007, 2008, as to whether or not pulsed electromagnetic field treatments would do anything to stem cells on the positive side. And we actually built an entire electrically isolated system to test a pulsed electromagnetic field device. I think it was the MRS 2000 or something like that. It was a long time ago. With stem cells in culture versus no PEMF. And we couldn't tell the difference between the cells. So I know there's quite a bit of advertising out there for PEMF being, helping stem cells. But when we actually did the experiment, we couldn't convince ourselves that it was worth buying a lot of these units to treat our patients. So again, that's our process, right? We don't just talk to a sales rep who says, oh, it's the best thing since sliced bread. With stem cells, our process is, okay, that's an interesting claim you just made. Give us a unit. We will test it ourselves on the cells in our lab. And if it performs, as you've said, we'll be your biggest customer. If it doesn't, we'll tell you to get lost. And for PEMF, we had to tell them to get lost.
There you go. That's the way you do it, though. You got to try it, test it, and see. Damien says, I definitely agree with you, Dr. Deitch, in terms of your unique approach, Dr. Centeno. Thank you, Damien. Appreciate that. Stacy Kaufman, hello, Stacy. She asks, are you familiar with and would you recommend FSM, frequently specific, I don't know if it's a typo, frequency specific microcurrent therapy to support PICL to heal soft tissue CCI injury before you can exercise?
Yeah, the biggest issue I have there would be you're talking about ligaments that are really isolated from the rest of the body and encased in bone. So it'd be very hard to get at these ligaments with any microcurrent. Same thing even with laser, same thing with PEMF. It's going to be very hard to reach these ligaments because they are so isolated in the spinal column, meaning they're surrounded by bone and they're topped off by bone. So it would be a hard thing to do to get anything at that depth that's going to work, even if you had a powerful laser. You may not have it actually touch many of the ligaments because that laser is going to be absorbed by the bone. So very, very hard to think that a frequency-specific microcurrent could get there. But heck, if someone, I would say this, if someone's used it and they found it to be helpful, then absolutely let's do that. And that brings up another topic. I know I've had a lot of questions through the years about hyperbaric oxygen. We're actually doing a small hyperbaric study right now that'll probably get started here in the next few months. And hyperbaric study is because people have asked us, does hyperbaric oxygen improve my stem cells? Do I need to do this beforehand? The answer is there really isn't any research done like we'd like to see it done. So we'll start some research on it and see if it actually helps and it's worth doing.
All right. I think this would be our last one. Stacy just follows up with the frequently specific microcurrent therapy for muscle atrophy.
Oh, yeah. So, Stacy, I don't know if there's been research done on muscle atrophy with frequency-specific microcurrent, but if you have some, please send it and I'll review it. Pretty sure you have my email address, so just send it to me directly.
All righty. That's our show for today. Doug, thank you very much for your comment. Thank you very much, Dr. Centeno and Dr. Deitch. So honest and informative. That's what we're here for. We do our best to provide you.
I lost your audio.
All right.
Looks like you're.
Here we go. How about now?
Okay.
How about?
Got it.
We good?
But no, you muted yourself again.
All right.
There we go.
There we go. All right. one of those technology days. Good days, not so good days. You can hear me now. We'll wrap it up.
Yeah.
Thank you everyone for joining us. That's what we are here to do, is to provide you honest and authentic resources so you can ask your questions and you can get answers that make sense. Not just dollars for the doctor, but common sense for you. And the more you understand the principles of healing and the difference between suppressing a symptom and activating the body's own healing, the more you will understand how to really easily put these different types of things into different categories. Is it designed to just suppress the symptom, or is it designed to actually get the body to heal physiologically and function at a higher level? That's really the main thing most people forget to even consider. And that's what we're here talking about here today, is how to get your body to do the most healing that it possibly can naturally. It's the name of the game. So, thank you for joining us for questions. Mondays, we're here at the Centeno Schultz page. Fridays, we'll see you at the Regenexx page. If you've got questions, this is the place. If you've got friends suffering, please invite them to be watching these shows with us on Mondays, Fridays. Let them ask their questions directly. And lastly, in closing, if you're wondering if you have coverage for any of these procedures at Centeno Schultz or the Regenexx Network, you can go to regenexcoverage.com. There are up to 8 million people that have coverage by your employer specifically, who has reviewed extensively what the Regenexx offering is all about and have come to the conclusion, this is smart, this makes sense. People get healthy, it doesn't cost as much on the system, people get back to work more productive and enjoying their families, and that's the name of the game. So if you'd like to know if you've got coverage for your next procedure, regenexcoverage.com is the place to go. Doc, closing comments on the different letters to talk about the different people, but know that really the place to go is someone trained on the Regenexx Network. Let's close up today's show together.
Yeah, I think it's just important to recognize what those designations mean. Again, you're looking for an MDDO who does this work, who has specific subspecialty training. Obviously, if you're local to Colorado, Centeno Schultz has got you covered there. If you're not, then the Regenexx Network has got you covered, because we do extensive screening and training, meaning there isn't a doctor that's getting on that network who doesn't have the training to do this stuff.
Good stuff. Thanks everyone for joining us here today. We'll see you Friday over at the Regenexx Facebook page. Thanks for watching. Make sure you click to get notifications when we go live so you're always well informed when we're live. Until Friday, have a great week, everyone. Thanks for watching. Stay well. Be kind.